Great. Welcome, everyone. Delighted to have people here in the room at UBC Okanagan, and also I want to welcome all of the people that are joined us online today. My name is Joan Batorf. I'm a professor in the School of Nursing and director of the Institute for Healthy Living and Chronic Disease Prevention. And we are delighted to host this seminar today. And I'd like to begin by acknowledging that the land on which we're gathered here today at UBC Okanagan is the traditional unceded territory of the Syilx Okanagan Nation and their people. We are host a series of seminars, and delighted today to do this one on cannabis. I want to just, before we start, remind our guests on webinar that they can pose their questions and comments in the chat box by typing those in, and Jaquetta will read them out to our speakers. And for those of you in the room today, I'd invite you to jot down your questions and comments as we go along. There will be time towards the end of the session for you to share those with our speakers. So without further ado, I'd like to introduce our speakers today. Dr. Zach Walsh is an associate professor in psychology at the Irving Barber School of Arts and Science here at UBC Okanagan. And also Tanya Sanich is a master's student in psychology here also at the Irving Barber School of Arts and Science at UBC Okanagan. So I welcome our speakers to the podium to talk about Cannabis Revisited. Thank you.
All right, thanks so much for inviting me and for the kind introduction. Thank you all for coming out. I'm going to talk today a little bit about some of early signals from our research looking at pre and post legalization of cannabis, and what that means for student health and also perhaps more broadly for public health. Some disclosure: I have received funding from licensed producers of cannabis, Tilray and Doja. The research that I'll be presenting here today, I think just a very small part of it has been a collaboration with Tilray. Otherwise, it's primarily supported by SHRC, CIHR, MyTax, and of course the Institute for Healthy Living and Chronic Disease Prevention, who have supported so much of my research. I probably wouldn't be a cannabis researcher if it wasn't for the Institute. So I can't thank Joan and the Institute enough for the support they gave me back when cannabis wasn't such a hot topic, when it was a risky gamble. So thank you for that. It made a big difference. I always like, when I talk about cannabis, I want to take it back because it's important that we recognize this is a very ancient medicine, perhaps one of the oldest medicines, medical relationships with the medical plant that humans have. The earliest signal that we have on human cannabis use is as a medicine. It comes from the writings of Shen Nung, the semi-mystical, the creature from Chinese history, the divine farmer and the father of Chinese medicine. This picture is not from 2700 BC, but it is from about 1500. So it's quite old, prior to our current conceptualizations of cannabis. And you can see there's Shen Nung, who, as I say, is sort of a deity figure, not a regular physician. Although, you know, since we're in the health building, physicians are deities of sorts, I suppose. But yeah, there's Shen Nung with a cannabis plant. And what this highlights really is that, you know, for thousands of years, cannabis has been seen primarily as a medicine. And one of my hopes with legalization is we can start to reconceptualize it that way again. It's not only from China, though. It appears in the Vedas from about 1000 BCE and associated with the god Shiva, who in this image is grinding up bhang, which is an edible form of cannabis that's widely used for in India, particularly around the festival of Holi, but also prominent in Ayurvedic medicine. And the Vedas, as I said, about 1000 BC, describe it as a liberator and something that's compassionately given to humans. And I think, when we see the resurgence of cannabis as a medicine, that theme of it being a compassionate medicine, a gentle medicine, keeps reoccurring. So much later, came to Europe through physician William Brooke O'Shaughnessy, who brought it from India to Europe. And today, if you are looking for reliable information on medical cannabis use, O'Shaughnessy's is a great place to go, an online resource that's named after Dr. O'Shaughnessy. So even midway through the 1800s, this was still a medicine, and it continued to be a medicine in Europe, referred to as cannabis. Queen Victoria was reported to have used cannabis quite regularly. So the namesake of our provincial capital, named after a strong female cannabis user, which is perhaps appropriate for BC. And certainly it was something that was endorsed by her court physicians. Unfortunately, most of what we now think of around cannabis is based on the Prohibition era. And one of the reasons I always refer to it as cannabis rather than marijuana is because marijuana was something that was invented to alienate people from what they already knew about cannabis. It was presented as this new entity. Harry Aslinger, never doubt that one devoted person can change the course of history, because Harry Aslinger almost single-handedly changed conceptions of cannabis. The first commissioner of the Federal Bureau of Narcotics in the 1930s, he didn't really pull any punches. Shortcut to the insane asylum. What was once your brain will be nothing but a storehouse of horrid specters. Of course, raises the question, what if your brain was already a storehouse of horrid specters? But this really highlights the kind of hyperbole and where we got in a different perspective on cannabis and renaming it marijuana. And what I hope you take from this brief history, that's actually not a picture of Harry Aslinger, that's Pinocchio. But they share a startling resemblance. What I hope you'll take from that is that really cannabis has a long history as a medicine, and its current era that's coming to an end of prohibition is really a short-lived, it's really a blip in the history of the human relationship with cannabis and cannabinoid medicines. So not long ago, we did a study of medical cannabis users. This was a long time ago in cannabis, medical cannabis in Canada history, but really quite recent, 2011, and funded by the Institute. And so grateful at the time. This is really what got us started as cannabis researchers. And we surveyed what was at the time the largest cross-section of medical cannabis users in Canada. And we found overwhelmingly that people were using cannabis for sleep pain, but also for anxiety and depression, which was surprising, particularly given what I showed in the previous slide, the concept that cannabis was really associated with poor mental health and with insanity even. So we were somewhat surprised to see that so many people were endorsing using cannabis to treat anxiety and depression. And so, we decided to look a little bit further, and we did this systematic review of cannabis and mental health, and it was a slightly, this slide looks a little weird, but it's a slightly unusual methodology in that we looked systematically and exhaustively at the research on cannabis for therapeutic purposes, all studies published from 1960 through to 2015, and we often, bemoan the lack of evidence around medical use of cannabis. It's true that we're still waiting on RCTs, but if we look at the number of respondents, the number of people that have engaged in these studies, it's about 24,000. So it's not that there's no evidence, it's just that there isn't sometimes called the gold standard RCT evidence for medical use of cannabis. When we talk about the non-medical use, it's voluminous. There's no way that anyone could review all of the stuff on cannabis and mental health. There's been so much research aimed at finding problems with cannabis and mental health, so we reviewed reviews. So there's a combination of a review of reviews of non-medical use and a systematic review of therapeutic use. And I'm just going to relate what we found about anxiety and depression, because that's what I want to focus on today. We found that 8 cross-sectional studies of medical users, several from California, some from Australia, the UK, and Canada as well, Across all of these studies, anxiety was reported as a primary or secondary benefit, anxiety relief. And in one case where they looked at what happened when cannabis use was stopped, a return of anxiety. So really seeing cannabis as a bit of a short-term symptom relief for anxiety, not unlike what we see with benzodiazepines. In the non-medical literature, we see a small positive association between cannabis use and anxiety, and not something that's been interpreted as causal. So of course, if people are using cannabis for anxiety, we're going to see a little bit higher anxiety amongst cannabis users. See a very similar pattern with depression. For some reason that didn't come out, but 9 cross-sectional studies of therapeutic use and 7 noted mood improvement. So, and in the non-medical studies, very similar, small positive association, but not something that speaks to causality. Rather, again, people who are struggling with low mood may be using cannabis to address that. So in general, even though it's not the highest standard of evidence, there is evidence that people are using cannabis to treat anxiety and depression, and not in small numbers. We also, if you'll remember that slide, looked at, saw pain as the #1 indication for which people are using cannabis, and that continues in more recent surveys, that people are using cannabis for a combination perhaps of pain and negative affect, and we know those things go very closely together. Particularly when it comes to chronic pain, that a lot of people also suffer with negative affect. That exacerbates chronic pain, and the pain can then lead to lower mood. So it's sort of a vicious circle of negative affect and pain, and they have a reciprocal relationship. In some of our prior studies, we were recruiting from medical cannabis dispensaries and medical cannabis resources, and that has a built-in limitation in that because of barriers to accessing cannabis, these are people who already found cannabis to be effective. Otherwise, they wouldn't still be accessing it. So in this study, also funded by the Institute of Healthy Living and Chronic Disease Prevention, we looked at arthritis patients broadly. So this wasn't just medical cannabis patients, this was arthritis patients, many of whom were using medical cannabis. And it's really important that we understand alternatives for treating chronic pain. You know, people suffering with arthritis and other conditions, arthritis just being the most prominent one, because the existing treatments have some pretty serious limitations. We're well aware of the limitations of opioids. Unfortunately, it's become inescapable over the last few years. But the limitations of non-steroidal anti-inflammatories are perhaps less prominent, but still considerable. And this study suggested that the cost of the medical complications associated with non-steroidal anti-inflammatories exceeds $4 billion a year, over 16,000 deaths per year in the U.S., and probably around 1,500 in Canada. So there is serious problems with other alternatives for treating pain. And I think what's important, especially now that it's legal, is that we look at cannabis in context and think about the pros and cons, the risks and benefits relative to other medications, rather than just looking at it in isolation. And that's what we did in this study. We were able to ask people who were using both cannabis and opioids or NSAIDs how cannabis worked. And what you see is really no different when it comes to directly reducing the pain. Cannabis is in blue. This is the percentage of people who very strongly agreed that it directly reduced pain. Cannabis is comparable to the anti-inflammatories and the opioids. When it comes to making the pain more bearable, it seemed to be more highly endorsed than anti-inflammatories, less irritating, allowing people to have a normal life. And when it comes to being less depressed about pain, cannabis was more highly endorsed than both the anti-inflammatories and the opioids. So our sense that perhaps cannabis is addressing not just the direct pain, but the psychological aspect of pain, making the pain less upsetting, and perhaps breaking that vicious circle of anxiety and pain. This seems to be consistent with that understanding. A subsequent study, and this is the one that we did with Tilroy, this is looking only at registered medical cannabis patients. So these are all people who have a physician's authorization to use cannabis for medical purposes, and looking at how they use cannabis as a potential substitute for some of these other substances. You know, things like opioids and benzodiazepines, antidepressants, they all have their own side effects, and they're considerable. So to the extent that cannabis can be used as a substitute, I think that's really where we see some of the potential public health benefits. And it's why I think it's so important that we look at cannabis in context. And when we look at those who are using cannabis primarily for pain, we see that they are largely substituting cannabis for opioids, and this is an area of growing interest. Later this month, the BC Centre on Substance Use, we're having a full-day symposium on cannabis substitution for opioids, and it's certainly top of mind for substance use researchers. And we see in this pain sample, yeah, over 40% say they're replacing their opioids with cannabis, but we also see a sizable proportion that are replacing benzodiazepines and antidepressants. That's in a pain sample. In a sample of people who are using cannabis for mental health, they're also replacing opioids. So it seems like it is this convergence of opioids and benzodiazepines together, perhaps antidepressants as well. So it's sort of that nexus of pain and anxiety where cannabis may be having its greatest effect. And that's important because when we think about the opioid overdose crisis, what's sometimes overlooked is the influence of benzodiazepines. So a sizable portion of the mortality associated with opioid overdose involves concurrent use of benzodiazepines. And a lot of high-profile cases, but across the board. So much so that the FDA has recently put out their highest warning on co-use of benzodiazepines and opioids, and there's a growing literature that's documenting this worrisome co-use. So if cannabis can serve as a single medication, the potential to replace both opioids and benzodiazepines, then we may see some real public health savings. And I'm sure I don't have to reiterate the severity of the opioid overdose crisis, but I think it's something that we can't keep prominent enough. So over 1,500 deaths last year in BC alone. Those are the overdoses. And of course, the first responders do such an incredible job of reviving people that 1,500 is really just a small fraction of the total overdoses that are attended to. So I don't think that cannabis is going to single-handedly solve the opioid epidemic, but with something of this magnitude, if it helps a little bit, then it can really save lives. So very important that we continue to look at this. And it's not just the research that I presented to you. There's other stuff from our team that has shown that people are using cannabis to reduce opioid use. And even in some marginalized, very high-risk populations, so street-involved youth, primarily in the downtown east side of Vancouver, we see that heavy cannabis use was associated with a later initiation of injection drug use. And we're currently following that up with the BC Centre, doing a more granular look at cannabis substitution amongst those high-risk opioid users. There's also some nice epidemiological data. Again, we don't have the RCTs, but we can look broadly at what happens when different states in the U.S. legalize cannabis and how that impacts the use of other medications. And what we saw is that in states that have medical marijuana laws, there was dramatic decreases in use of prescription drugs through Medicare, where they track it, and they were not insubstantial. So hundreds of millions of dollars per year being saved due to substitution. Of course, the concern as well is that one of the risks with cannabis that certainly is top of mind is driving. You know, we've seen the devastation of alcohol-impaired driving. The impairment of cannabis on driving is certainly not equivalent to the impairment associated with alcohol. And to the extent that cannabis can serve as a substitute for alcohol, we may actually see safer roads with easier access to cannabis. And a couple studies have borne this out, where there's decreases in traffic accidents, and some other studies that have gone a little bit more granular have shown that those co-occur with decreases in alcohol-related accidents, particularly, and they're most prominent in the age group that's most likely to use cannabis. So in general, of course, we want people to not use cannabis when they drive, but at a population level, it may be improving rather than damaging road safety. So taken together, I hope I've suggested that the legalization of cannabis may not be really a lesser evil, but it may actually be a public good. And so we wanted to be able to study that. This is great as a researcher that we have this massive intervention. Usually it's on us to do the intervention. In this case, the government stepped up and intervened by legalizing cannabis. And they also provided some funding. So CIHR funded through a Catalyst grant the metric study, and I'm going to talk a little bit about some preliminary findings from that today, and I'm going to have, Tatjana is going to follow up and give you a little bit more detail about it. The goal of our study was to see how legalization impacted levels of use, attitudes, the use of other drugs through substitution, as I've mentioned, and whether that has downstream psychosocial health consequences. And we also looked at moderation by gender and ethnicity. And we'll talk a little bit about that. And the study is now funded by SSHRC for a longer follow-up. So one of the first things that we needed to do in order to refine our study of cannabis was to find new ways to assess it. The existing tools have all been developed under prohibition, and they really overemphasize problems. And it's an issue in cannabis research. When we talk with medical cannabis users in particular, we're stuck with these tools that only query problems. And they can potentially be stigmatizing and quite frustrating for respondents who don't feel that their experience of cannabis use is being adequately captured by the measures. We also don't have standardization of cannabis use. A lot of research has been very broad in its assessment of cannabis use. People are labeled as cannabis users, yes or no, they're daily users or not, but we don't really get a sense of how much people are using cannabis, and part of that is we have a problem with standardization of units. So our goal is to improve cannabis assessment, and as part of the metric study and our ongoing research, we've done a bit of that, and I'll tell you a little bit about it now. The first step is we've developed the brief composite cannabis assessment tool, so the BC-CAT, and it concurrently measures problematic recreational and therapeutic use in one measure. And it's meant to be brief. Our hope is that this is something that clinicians can use to get a more holistic picture of how people are using cannabis. And it can be broken down into 3 scales. So we get a sense of some of the key problems. And if you look at, I'll just show you the next page. And this is what we're also refining with the high-risk sample on the downtown east side. But in terms of therapeutic use, we look at substitution, pain relief, sleep, and nausea. And we had a much broader item set that we refined. So this is refined down from about 35 items to these 12 that loaded most highly on these factors. We've run this with several thousand respondents. So we're just getting ready to publish this tool. In terms of negative effects of cannabis, problems, refraining from activities, difficulty controlling use, negative feelings about use, difficulty stopping, and then just general positive use of improving mood, thinking differently, relaxing. You know, now that this is a legal substance, I think we have to acknowledge that people engage in recreational activities, and that has a good to it. In terms of measuring cannabis use more closely, we want to find some kind of equivalency across different modes of use. So as some of you are aware, and I was just speaking with Joan earlier about vaporizing, how do you equate vaporization with using a bong or using an edible or smoking joints? We don't really have a good way of doing that because of the pharmacokinetics of cannabis. You can't just talk about milligrams of THC because the psychoactive effects are very different depending on mode of ingestion. So we thought the best way to do this was to ask the experts, ask people who are using cannabis on a regular basis. So we got a pretty large sample of cannabis users and asked them to try to equate what's a low dose, what's a medium dose, and what's a high dose across these various modes. Most of our respondents had used all of the above. And just to illustrate, there's the classic joint, there's pipe, there's edibles, brownies, etc. There's bongs, which are still popular. And important to distinguish amongst vaporization, there's the herbal vaporizer, which is probably the most healthy way to use cannabis, maybe edibles, but this just heats up the herbal cannabis so that it releases the THC and other cannabinoids. The concentrate vaporizers have THC and other cannabinoids mixed with some kind of excipient oil, and that's where we're seeing some of the health concerns because we don't know quite what is being added to the cannabinoids, and I think that we don't know quite why we're seeing these lung problems, but the best bet is that it's some of the additives to the cannabis that make it accessible via vaporizers. And then there's dabs, which is a really high concentrated use of cannabis. You heat up a pin to a very high heat and drop the pretty much pure THC on it. I don't think anyone in this room needs to know more about dabs. But we can talk after if you'd like. So when we look at these different equivalencies, we want to see by tolerance. People might be different depending on their tolerance level, what they thought was a high dose. When we look at a joint, which is something that most people are familiar with, it looks like we could all agree, or most of the respondents agreed, that a low dose of a cannabis joint was 2 or 3 puffs. A medium dose was somewhere between 5 and 10, and a high dose was pretty much smoking the whole joint to yourself. Things really separated when we looked at edibles. So everyone could agree, I think 5 milligrams is a pretty standard starting point for people who are using edibles, and everyone put a low dose at less than 10. The medium dose things started to diverge, and when we get to a high dose, people with high tolerance were able to go really high on that. So just because your Aunt M tells you that the brownies are mild, you want to check her tolerance first, because what she thinks is a mild brownie may not be your mild brownie. And with a bong, just about everyone agreed that 6 bong hits was plenty. So this is our preliminary measure. You can see that there's nice separation between low, medium, and high dose. What we're most interested in, though, is getting a simple unit that was going to be equivalent across modalities, sort of like a standard drink, right? We all know that a beer is equal to a glass of wine is equal to a shot of hard alcohol, and we wanted to try to find something like that for cannabis. And what we came up with ultimately is the standard cannabis unit, and we're preparing this for publication now. It's 2 hits off a joint or a pipe or a concentrate vaporizer. Herbal vaporizer takes a little bit more, 1 bong hit, a quarter of a dab, or a 5 milligram edible. So hopefully down the road when we're doing cannabis research, we're going to be able to talk about a single unit and equate it amongst these different ways of using. And that's going to be important for realizing the goals of the metric, one of which is to assess levels and modes of cannabis use. How do we know if people are using more or less cannabis when really there's all these new ways of using cannabis that are opening up around legalization? I think we're just a little over a month away from the time when concentrates and edibles will be available in shops in Canada, so just in time. So the other thing we're looking at, the other things we're looking at in the metric were cannabis-related cognitions, and Tatiana's going to talk about that in a moment. We're also interested in how it uses other substances. I'm just going to give you some preliminary signals on this, and thanks to grad student Joey Rootman who prepared these slides and is leading up this part of the research. So this is based on UBC students, about 1,000. These are all students who have lifetime use of both alcohol and cannabis. And it's important to determine whether cannabis is going to be a substitute or a complement to alcohol. Quick way to think about that is to think about popcorn at a movie. The more popcorn you eat, the more you're going to drink. So you might want a larger drink. That would be a complement. However, the more popcorn you eat, you're probably going to, if you get nachos, you might eat less popcorn. So nachos would be a substitute for popcorn, whereas your beverage would be a complement. And what we found is that only about 4% of students said that cannabis made them drink more. So it was pretty rare for it to be a complement, whereas over half of them said that it was a substitute, that they drank less alcohol when they were using cannabis. And we know, I don't have to reiterate the health risks associated with heavy drinking, and Joey's looking at that for his master's thesis at a more granular level, whether cannabis actually reduces high-risk binge drinking amongst our students. So maybe next year we can share some of that information with you. What's interesting is that we found that 1 in 10 are purposely using cannabis to reduce their alcohol consumption. I'll let Tatiana give you a more detailed view of rates of use post-legalization. What we found on campus is very similar to what is showing up in the large national surveys. No real change in levels of cannabis use, particularly amongst younger adults. Some increase amongst older adults. So seniors are using more cannabis post-legalization, but for everyone else it seems to be pretty much the same. We actually saw a slight drop, not statistically significant. What we did see as different pre- and post-legalization, though, is in the reasons why people use cannabis instead of alcohol. So prior to legalization, over half, about 56% said that they thought cannabis was safer. That dropped to 40% as a reason why people are using cannabis instead of alcohol. Interestingly, about 30% before said they used cannabis if they had to drive. So they would be the designated driver and they'd use cannabis instead of alcohol. And that's cut in half. So potential reasons for this is maybe some of the messaging around legalization. It seems to be working. People are not using cannabis more, but they are perhaps getting a more realistic assessment of some of the risks of cannabis use and able to discuss it. So I think during the experience of many people during criminalization of cannabis is that you couldn't trust anything the government was saying because they had exaggerated the risks for so long. And it seems that perhaps with legalization that some of the messaging around driving and around safety may be having an impact. And certainly that was part of the goal of legalization, was to facilitate clear and open and honest communication. And I think some of the data that Tatiana is going to present speak to that as well. So that's just a quick snapshot of what we found pre and post legalization. It's still very early. It's hard to really know what the signal is because concurrent with legalization has been a reduction in access. So there used to be more dispensaries in Kelowna and across BC before it was legal than after. So it's hard to know. We're kind of getting different effects based on access and legalization. So we want to follow that up with a longer-term analysis, and we will be continuing this study for a number of years. Some other stuff that's coming out of our lab is a behavioral economic analysis of price and substitution. So at what price do people choose cannabis over alcohol, and how does that impact it? We're looking at substitution amongst a higher risk population, so we're doing that in Vancouver. We want to look at older adults and see how substitution might play out in those groups, because those are the people who are suffering the most from the ill effects of non-steroidal anti-inflammatories. And finally, we're looking at interventions for problematic cannabis use based on mindful cannabis use. So it doesn't have to be an abstinence model, but how can people talk about using cannabis in a more mindful and effective way? And so with that, I'm going to hand it over to Tatiana, but I just want to acknowledge all the great students in our lab that are helping out. Kim Crosby, Michelle St. Pierre, Tatiana, who you'll meet, Sarah Daniels, and Joey is here as well. So thank you very much, and welcome, Tatiana.
All right. Hello, everyone. As Zach mentioned, my name is Tatiana, and I'm here to present one part of the project from the metric study, and this part specifically focuses on the social norms of cannabis use in UBCO students. So during the introduction, I'll discuss what we know about social norms and the important moderators to consider when we're discussing social norms, as well as what we need to consider in the context of federal cannabis legalization. I'll also discuss our current study objectives and the procedure, and lastly, I'll discuss some of the results and implications of the study. So what are social norms? Well, social norms are unwritten rules about how to behave. They provide us with an expected idea of how to behave in a particular social group or culture. So they're the accepted standards of behavior of social groups. An example of this in our culture could be something as simple as giving up your seat on the bus for somebody who's pregnant, or tipping at a restaurant. So they're generally broken down into two distinctive types of norms. So the first ones are descriptive norms, which are the perception of what's actually done by most others in one social group. So if I ask you, for example, what percentage of your friends would leave a tip at the restaurant? And injunctive norms. So these are the perception of beliefs about how one ought to behave, and again, coming from one social group. So if I asked you what percentage of your friends would approve of you leaving a tip for a server at the restaurant? And both of these norms provide codes of conduct for adaptive behavior in social contexts, and both of these norms can be constructed from information obtained in observing and communicating with others, and in making comparisons to the self. However, each of these sources of information is also vulnerable to cognitive distortions, and combining them creates potentially inaccurate information that can lead to errors in perceived norms and an overestimation of others' action and approvals. So extensive research has examined these perceptions and misconceptions and found that they can be informative of an individual's health behavior in a number of different categories, including eating, dieting, engaging in risky sex, and of course in substance use, which is what we'll be talking about today. So what do we know about norms in cannabis use? Well, the majority of the research actually started around the social norms of alcohol use, but what we found is that a lot of those findings are actually applicable to cannabis as well. So basically, students who perceived lower peer use of cannabis are less likely to initiate cannabis use in the future, whereas youth who report higher perceived peer use of cannabis have greater odds of personal cannabis use. And what's interesting is that the perception of peer use is actually more predictive than how many of their friends are actually using cannabis in the real world. And in addition to asking about perceived cannabis use in peers, some researchers have also started asking about perceived cannabis use in parents and whether that affects their own cannabis use. And youth have reported that their parents' use of cannabis actually also increases their own likelihood to use. So we know that the descriptive norms of cannabis use are predictive of these different cannabis use patterns. In addition, social group disapproval of cannabis use has also been found to have an inverse relationship with cannabis use. So in a study assessing grade 12 students in the US between 1976 and 2006, researchers found that the highest levels of approval of cannabis use preceded the highest levels of cannabis use, which occurred around 1978. So we see this long-standing pattern of perceived peer approval of cannabis use leading to an individual's own approval. And likewise, parental disapproval of cannabis use has also been associated with lower odds of cannabis use. So whether students perceive that their parents and peers approve of their cannabis use has an effect on their own use. An overestimation of peers' use and peers' approval of cannabis use has been found to be common among adolescents. So this error in perception is also predictive of future cannabis use. So for example, if you ask the average UBCO student how many of their peers are using cannabis, and they say something like 80%, where in reality it's actually closer to 40%, then that error in perception itself is also predictive of that person's willingness to initiate cannabis or cannabis use patterns in the future. Now there are a couple of moderators that have been found to affect the social norms of cannabis use, and the first one of course is gender. So what we see with gender is that women report facing more stigma for using substances in general, including using cannabis. So the use of illicit substances has typically been associated with traditionally masculine values, such as risk-taking and excitement-seeking, while the same drug use by women is seen as jeopardizing feminine values and labeling women as deviant. So studies have shown that women report less approval of their own cannabis use compared to men, and they tend to police themselves in all sorts of different ways. So for example, by smoking only in private places, or by policing the level of intoxication in public settings. In addition, they report being on the periphery of cannabis access networks, as very few women report having direct contact with a dealer. And of course, all of this research happened before legalization, so that's why we wanted to focus on gender as well when we're looking at the post-legalization context. And then the other big moderator that comes up is cannabis use history, so whether the youth have used cannabis in the past. And basically we see that individuals who use cannabis more frequently tend to have more permissive norms of cannabis use. So they report that their friends and other peers use more cannabis and that they approve of their cannabis use more. So why look at social norms right now? Well, of course, as Zach mentioned, this is the cannabis legalization era, so we really wanted to see whether specifically cannabis legalization would affect all of these like early indicators of cannabis use patterns in youth. And of course, one of the main reasons for recreational cannabis legalization was to, quote unquote, keep cannabis out of the hands of youth. And this was a very widely debated part of the policy, with some people saying that, you know, legalizing cannabis is just going to give kids the message that it's fine and everyone's going to use it, and some people saying, well, actually, that might not be the case. So one of the ways to conceptualize this change in drug policy is to view it as a marker of the shifts in the collective norms of our society, especially because cannabis legalization was something that was widely supported by Canadians in general. So the aim of this project was to assess whether the legalization of cannabis use had any effect on the social norms of cannabis use in youth, which as I explained earlier, have this really strong tie to cannabis use patterns and trajectories of use. And in addition, we also wanted to assess whether gender or previous cannabis use were moderators of this effect. So as I mentioned before, the participants were actually undergraduates enrolled here on campus between 18 to 25 years of age, and they completed an online survey through SONA for either 2% course credit or entry into a draw. And importantly, we didn't assess the same people before and after legalization because there's actually an age factor that comes into play. So when youth age especially, there's this natural increase in more permissive social norms of cannabis use. So we wanted to control for that by assessing the same or a different group of students pre-legalization and post-legalization. So this is sort of what the data collection timeline looked like. So the survey came online in February of 2018, and we wrapped up the data collection for this particular analysis at the end of April. But it's actually, the metric project as a whole is still ongoing. So we used 4 different types of measures, looking at descriptive norms in parents and peer groups, and at injunctive norms in parents and peers. And the descriptive norms of parental cannabis use just basically asked, for each of these people, please pick one category to describe their use of cannabis, and the students had a choice from never to very heavy, and we basically created a mean parental cannabis use variable with that. And then for the descriptive norms of peer cannabis use, we gave them 4 different peer groups, and they answered the question of indicate the percentage of each of these groups who use cannabis. And then we created a scale, so we summed up all of those percentages into a scale ranging from 0 to 400. For parent injunctive norms of cannabis use, again, we had the 4 different parents, and we asked how much would your parents approve of you using cannabis, and the scale went from strongly disapprove to strongly approve. And very similar for the peer injunctive norms of cannabis use. Again, we had the 4 peer groups, and we created a scale with those responses, so the scale would go from 4 to 16. So in terms of the results, we found slightly less students in the post-legalization sample, but that's just because we stopped collecting the data to be able to analyze it for this project. But as I mentioned, it's still ongoing. As is typical of university samples in data collection, it is mostly female, and the mean age was somewhere between 19 and 20 years old, and mostly Caucasian. So one of the things that we found is that about 38% of the sample reported past month cannabis use pre-legalization, and around 35% reported past month use after legalization, but there was no significant difference, so we can say that that's pretty stable so far. So in terms of the results of descriptive norms, so this table just shows overall frequencies of parental cannabis use. And what you can see is that close to 90% of students reported that their parents never or rarely use cannabis. So a very large percentage. So going forward, we actually dichotomized the categories into never use and some use, just because such few people were saying that their parents were very heavy users of cannabis. So we ran a logistic regression with the predictors of legalization, past month cannabis use, and gender. And what we found was that there was a legalization by cannabis use history interaction, as you can see on the graph up there. So cannabis non-users in the post-legalization group actually reported lower levels of parental cannabis use, and there appears to be lower parental cannabis use after legalization. And cannabis users showed a trend towards reporting increased levels of parental cannabis use, but it wasn't significant. In terms of the descriptive norms of peers, so again, looking at the means over here, remembering that it's from a 0 to 400 scale. So really, the easiest way to think about it is just divide it by 4. So around 40%, peers reported around 40% of their peers were using cannabis. So to analyze this, we ran factorial ANOVAs on the total score of peer descriptive norms, and we found no significant main effect of legalization. However, we did find that males indicated higher prevalence of peer cannabis use compared to females, and same with cannabis users. So cannabis users indicated higher levels of peer prevalence of cannabis use compared to non-users. So in terms of the injunctive norms, so this was all about approval. So this table shows the frequencies of parental approval of cannabis use, and what you can see is that around 70% of students reported that their parents disapproved or strongly disapproved of their cannabis use. And because we had such few people reporting strong approval of use, we actually dichotomized the categories again into approve and disapprove. And we ran a logistic regression with the predictors of legalization, past month cannabis use, and gender. And there was no effect of legalization on parental approval of cannabis use, which was surprising because we had found that effect on on descriptive norms of parental use, so how much their parents were using, but not any effect on their parents' approval of their own use. However, we did find that cannabis users reported higher levels of parental approval across the board. And lastly, we looked at the injunctive norms of peers. So remember again, this is for the scale that we created that went from 4 to 16. So the means were around 11 for pre and post legalization. And we found an interaction between legalization and gender, which you can see on the chart. So it appears that females reported higher levels of peer approval of their cannabis use after legalization, whereas males showed no significant decrease. And again, we found that cannabis users reported higher peer approval across the board. So in summary, university students who did not use cannabis reported lower levels of parental cannabis use after legalization, but there was no change in parental approval of cannabis use. In addition, there was no effect of legalization on the perceived prevalence of peer use after legalization. And it appears that legalization in female students reported higher approval of their own cannabis use after legalization. And it appears that legalization increased the perceived approval of cannabis use among the group that faced the strictest forms of social control previously, which were these female students. Male students showed no changes in cannabis use approval as they faced the lowest levels of stigma for their cannabis use even before legalization. And importantly, actual levels of cannabis use and perceived levels of peer cannabis use did not increase in university students, despite acute concerns that this was going to be one of the major costs of legalization. So in terms of future directions, of course, the main one would be to continue to keep tabs on social norms as we move forward. So since this data was analyzed in the summer, we've actually recruited, I think, over 500 more students into the study. And this is something that we're going to continue to monitor, especially because it took Kelowna so long to open up those legal dispensaries and to get everything on board. So as access to cannabis stabilizes, this is, of course, something that we want to continue monitoring. And of course, as Zach mentioned, as edibles come on board as well, it'll be important. So in addition, future studies will continue developing the scale that we used here to measure the norms of cannabis use, and also assessing the effect that cannabis use norms have on alcohol use norms as well. So seeing if that makes, the approval of cannabis use higher or lower or anything like that. All right, thank you for your time.
Some time for questions and comments. Zach and Tatiana, if you want to come up. So I'd invite those who are online, and we have about 20 or more people online, to add any comments or questions you might have in the chat box, and Jaquetta will read them out. And I invite people in the room to raise your hand, and I think, are the microphones working? No. So you might try the microphones or speak very loudly. So love to hear any comments and questions you might have for either of our speakers. Yeah, we'll have...
Hi, what were 70% of the respondents female?
Pardon? Why were 70% of the respondents
Yeah,
female?
do you want to just speak a little closer to the mic? Yeah.
Yeah, that's a good question. We see that a lot with samples recruited in universities in general, and it's probably because the enrollment for psychology courses is much higher among females, and that's generally where they would get, advertising for these studies, and that's where they would get the course credits from.
The therapeutic effects of marijuana, and you talked to the age group between 18 and 25. I used to work in forensic psychiatry at Center Addiction Mental Health for years, and one of the things I found interesting was the amount of new schizophrenics or severe mental illness in that age group. And I would work in admitting on occasion, and the frequency of the people that, or the clients that would come in and say they had a history of smoking marijuana. And I guess my concern with the whole legislation was, and it kind of ties in a little bit with my concern with the developing brain, and then, I always used to say to my kids, I said, if you're going to do drugs or marijuana, when you take 25, your brain cells in, your neurotransmitters is not growing anymore. So I'm wondering if there's any studies looking at that and the potential counter effects, they're not positive effects of marijuana, 18 to 25 age.
Yeah, so you're asking about concerns around psychotic disorders and cannabis use and how the age window for that and how legalization might impact that. I think that's a huge question and certainly something that's top of mind for a lot of us. The issue of cannabis and psychosis is still being pretty hotly debated. I think what is pretty clear is that for people who have a predisposition to or vulnerability, a genetic vulnerability for psychosis, cannabis use can lead to potentially an earlier break. But even that evidence is not as strong as it sometimes appears, because there's a lot of suggestive evidence that people who have a vulnerability for psychotic disorders are more likely to initiate cannabis use to treat prodromal symptoms. So even when we see some kind of temporal precedence where people use cannabis and later develop psychosis, that's not as clear as it might be. But certainly when you talk about the real risks of cannabis use, the earlier development of psychosis is certainly one of the most prominent ones. Having said that, we've seen dramatic increases in rates of cannabis use since the 1960s, like several hundredfold in Western societies, while rates of psychotic disorder have remained steady. So in terms of provoking de novo psychosis, I think that while it's not a total consensus, I think the sense that most have is that it doesn't cause psychosis on its own, but it may lead to an earlier break, and of course that's quite a substantial concern. Around the developing brain, and I know that there's been some controversial suggestions from different physicians' bodies suggesting that 25 be the age, and I can't say that I agree with that. I mean, the reason why we allow people to do things at 18 rather than 25 is not because they become safe, but rather because at 18 is when we allow people to make decisions about risky behaviors. And certainly we allow people to make risky decisions at age 18 about things that are far more dangerous than cannabis use. So I wonder if it's deciding that it's safe or deciding that it's something that's safe enough that people can make that choice the way they do around alcohol or other issues.
The concern I guess I had was when I was the THC levels in the current cannabis compared to the 70s.
Mm-hmm. Mm-hmm.
It's so concentrated.
Yeah.
And you can see, kids coming in and just really psychotic.
Mm-hmm.
What do you have? What is the strain that you're just on? And I knew a bit about this stuff being a child of the 70s.
Yeah.
But at the same time, I just wish you hadn't done that. With THC amounts that I find are so extreme now. You're looking at 55% from THC that you can buy from these places in the morning. And it's
Mm-hmm.
starting there. And with no education, no understanding really what they're getting into. I guess that's...
And with dabs, perhaps even almost higher than 55%, some of it's pure THC. And I think, I would certainly counsel people to use a balance of THC and CBD if they do decide to use cannabis, because I think CBD can mitigate some of the unpleasant effects. But there is some exaggeration around the idea that cannabis is much stronger. There's always been things like hashish and high concentrate highly concentrated cannabis products. There's also been high THC strains for a while. It's just on average the higher THC potency has been more available since people have developed indoor cultivation. And it's really an unfortunate side effect of prohibition. That's why the high concentrate THC cannabis has been grown, because it's more efficient in an illegal market to have a highly concentrated product. My hope is that with legalization, we're going to see more uptake of weaker cannabis. Just the way that, during prohibition of alcohol, people were drinking bathtub gin, and now they've reverted to light beer and wine. I expect that, as the market matures, we'll see more people going back to less concentrated THC products.
Yes, go ahead.
In one of your tables, you had it broken down by high tolerance, medium tolerance, low tolerance. What determines tolerance for cannabis?
Well, we just ask people their own perception of their tolerance. One of the things that's interesting, I think, about cannabis tolerance is it develops so quickly and it disappears very quickly. So even people who are heavy users, their tolerance goes back down after a few days. But I would imagine that in our sample, we sampled medical users and non-medical users, and a large portion of the high tolerance folks were medical users who are using cannabis maybe several times a day. So we wanted to know what they thought a low dose was and a high dose.
So even for those heavy users, if you restrain from using cannabis for a chunk of time, you go back to a baseline?
Yeah, that seems to be the case. The endocannabinoid system is very elastic.
It's very different than alcohol tolerance.
Yeah, it develops and diminishes much more rapidly than alcohol or opioid tolerance.
Great, thank you.
Just a question following up on the question about the 45-year-old brain versus the I just wonder if you could elaborate a bit on that. I'm not sure if I understood the answer correctly, in that perhaps the age 25 is that, at least for males, females tend to mature a little bit earlier, but if we think that the brain for the male is perhaps mature around age 25, is the age 18 of legalization a bit of a red herring, in that maybe we would advocate that one choose to use substances later on to prevent any adverse effects from on the developing brain?
Can you summarize the question a little bit?
Whether or not legalization misleadingly suggests that cannabis use is safe at 18 versus...
Or just maybe the recommendation might be that if you were to give one, that perhaps a brain that's closer to 25 versus 18.
I think that's based, it's primarily a theoretical recommendation. I don't know that we've seen differences in people who initiate cannabis use earlier compared to later. I mean, very early use, but from 18 to 25. And, when we look at those studies, I think they have to be interpreted very cautiously, because young people who are using cannabis on a regular basis, and that's where we see a lot of the data about the early use causing downstream consequences, those are kids who are, until recently were breaking, or still would be breaking the law on an almost daily basis. So there's a lot of confounding factors with those individuals, whether it's parental supervision or personality factors around, antisociality or rule breaking, that it's really tough to tease apart. I think as a parent, I would like my kids to be as safe as possible and not do anything dangerous at any time. But when it comes to some of the choices that they can make at 18 around alcohol, around skiing, around a number, I think it's remarkable that we applaud as kids get concussed on the hockey rink starting at age 7, but we wring our hands about 19-year-olds using cannabis. So I think yes, it's probably best to wait as long as possible before taking any risks. But I think the general social norm around allowing people to make choices to engage in risky behaviors around 18, I still think it's appropriate.
You have a comment?
I do. I have a comment. So, with the ICE standards of cannabis results in determining these standards, were you looking at differences in gender, or were there any psychological factors looked at?
I think we do have some moderators in the data set that we'll be looking at. And when it comes to, I know the drinking guidelines, a heavy episode of drinking is 4 drinks for females and 5 for males. So there could be gender differences in what constitutes a binge or a particularly high rate. But I think when we come to a standardized unit, we're going to want something that can apply across gender. But that's a great question, and something we'll look at when we write it up, is what were some gender and sex differences around those ratings.
Well, this has been a wonderful talk. I want you to all join me in thanking both Tatiana